Hey guys, welcome back to my channel. Today we are going to discuss ICD-10-CM coding conventions. Remember, the coding guidelines help you outside the book. The coding conventions help you code what's inside the book. ICD-10-CM guidelines, official guidelines, do not replace the conventions, okay? Let's get into it.
Don't just watch, take that leap. Medical coding pays while you sleep. Tap, share, follow, don't delay.
Okay, guys, first, before we go through them, let me tell you what conventions do. Conventions help you interpret the code book, all right? They tell you how to read the tabular list and the alphabetic index. Remember, the alphabetic index is the first half of the ICD-10-CM code book, and the tabular list is found in the second part of the ICD-10-CM book, all right? So they're part of the classification itself. These are not extra advice added later. So for example, conventions help you know when an X is a placeholder, when a note means code first or use additional code, and how to understand terms like with and other. All right, so let me just explain how they differ from the guidelines. The official coding guidelines are more like the rules for applying the code. So remember, guidelines are like the rules for applying the codes in real world coding situations. They give additional instruction for coding and sequencing, okay? But they do not replace the conventions in the code book. All right? So if the conventions tell you or instruct you to do something, follow them before the guideline, all right? So in other words, I just want you guys to just hone in on this so you know why you're using and why it's important to pay attention to your conventions. Conventions tell you how to read the ICD-10-CM, while the guidelines tell you how to use it correctly when coding a patient record. And when we get into examples later on, all right, in the channel, and let me stop here, guys. If you haven't subscribed to the channel and you're interested in inpatient medical coding, go ahead and subscribe and turn your notifications on, because I'll be uploading this. We need more inpatient coders. And if you need more structured, I invite you to go in the comments or in the description and click the link, guys. There is a blueprint, 8 to 9 week official blueprint that you can actually take the course, and it will qualify you or train you to sit for a HEMA CCS or CCA. All right, so don't forget, let's get into it. Here we go. We're going to start with NOS. NOS is not otherwise specified or unspecified. That means the doc didn't give detail, all right? And we'll look at examples later. NEC is not elsewhere classified. I want to point out to you guys, all right? NOS, not otherwise specified. NEC, not elsewhere classified or other specified. The doctor or the physician gave detail, but there's no exact code for it. Brackets show extra information in the index, okay? They flag a manifestation that's coded second, and we'll look at examples of these as we go. Parentheses is a convention. Parentheses hold non-essential words. They don't change the code. Excludes one. I remember when this came out, it caused a frenzy, okay? We did not, coding professionals, well, for the most part, I can't speak for all of us, but I know in my huge circle, we were scrambling to kind of understand excludes one and excludes two. But here we go. We have it together now, okay? Excludes one, never together. These codes are mutually exclusive, and we'll look at an example as we go. Excludes two. It's okay to code these two codes together, so we can code both if documented. Okay, and remember, you will find your conventions in the tabular. All right. Sometimes they are in the alphabetic index. I'm thinking about the non-essential modifiers, and we'll look at an example of that as we go with this video. NOS, not otherwise specified. It's not specific. Used when the note is too vague. So for example, we have pneumonia. The note just says pneumonia. So when you go to the alphabetic index, the pneumonia is not, excuse me guys, COVID. It's not viral. It's not bacterial. You have to stop at pneumonia. There was no organism specified. Okay, so we're going to code that to just J18.9. Anemia. The note just says anemia. No type, no pernicious anemia, no acute blood loss anemia. The doctor just wrote anemia, right? We're going to code that to D64.9. Oitis media. The note just says ear infection. It has no laterality, meaning there's no left, there's no right. It's just unspecified, okay? And if you look at the fourth digit on these, we'll notice that it is a 0.9. Usually 0.9 is unspecified, all right? NEC, not elsewhere classified, simply means other specified. NEC, the doctor gave a specific description, but the book doesn't have that exact one, all right? So there'll be diagnoses that the manual, the coding book, just doesn't provide a code for. However, if the doctor specified the diagnosis, then it is specified. It's not unspecified. And this is where we have NEC, all right? These codes often end in 0.8 or 0.89. So let's look at this one. Doctor writes a specific dermatitis not listed by name. So I give the example, doctor wrote in the progress note, googly dermatitis, all right? We know itis is inflammation or infection. We know derm is about the skin, all right? He says, you know, googly dermatitis. That's not really a diagnosis, guys. It's just an example that it is specified. Googly is just not in the index or the tabular, okay? So because the doctor specified it, it is not unspecified. It would code to L30.8, and that's as this recording, okay, 2026. J84.89, other specified interstitial pulmonary diseases, because the physician documented a rare ILD. It's not listed, but he did say it was rare. And he won't say it's rare. I just did not put like what was in front of interstitial lung disease, just to show that because he did name the interstitial lung disease, we did not see it in the tabular or the alphabetic index. So therefore, documentation does justify and other specify. It's not just unspecified because it wasn't listed in the alphabetic index, okay? So this is how we contrast NOS versus NEC. NOS, not enough info in the note. NEC, plenty of information in the note, but no precise code exists. Let's look at brackets. Brackets do two things. So in the index, the alphabetic index, that's the first half of the ICD-10-CM book. Bracketed codes are manifestations that you code second. In the tabular, brackets can show synonyms or explanations. Let's look at what that looks like. So in the index, the etiology, then the manifestation. Etiology is what caused the manifestation, okay? Manifestation is the spin-off of the etiology. Parkinson's disease with dementia. We have G20, which is the etiology. We have F02.80, which is the dementia. Documentation states Parkinson's disease with dementia. In the index, when we go to Parkinson's, right, We go down to dementia because we have a with. So the sub-entry, we're looking for dementia. Next to that, in the alphabetic index, we will see G20, and we'll see a bracketed code of F02.80. We're going to code the cause first, G20, the dementia second, F02.80. Brackets signal the second code. Okay? This is very important. Say, for instance, a patient arrives from the nursing home to the emergency department. Documentation states the patient is altered, a little loopy, doesn't know the date or the time, all right? Not even her name. Altered mental status. In the note, the physician writes altered mental status due to dementia, right? And we know it's documented that the patient has Parkinson's disease, okay? So for this encounter, we're looking at principal diagnosis selection. The note clearly says the patient's altered mental status, all right, was due to the Parkinson's disease with dementia. When you're looking for your principal diagnosis, which is the condition after study to have occasioned the patient to the hospital for care, because G20 represents the etiology, which is Parkinson's, we're going to sequence G20 as our principal diagnosis, followed by F02.80 to represent the dementia. The altered mental status in this case is a symptom code. We would not include it because the physician has linked it to a definitive diagnosis of the patient's Parkinson's disease with dementia. Okay, now I wanted to point this out. Principal diagnosis, only one code. So say the patient presented with shortness of breath. After study, the patient was found to have pneumonia. We know right then we're going to put the pneumonia as principal diagnosis, okay? Shortness of breath is a symptom of the pneumonia. We would not code the shortness of breath. As we go through the chart, we notice that our patient does have Parkinson's disease with dementia. So as an additional or secondary diagnosis, we're going to code the G20 and the FO2.80. In this case, it doesn't matter if you have G20 on line 3 and FO280 on line 5, because sometimes when the grouper groups the codes, it will not remove your principal diagnosis, but it can scramble the other, how you list them. So as additional diagnosis, you may not have G20 and FO2.80 together. So as a secondary diagnosis, yeah, it matters, but it kind of doesn't, long as you have both codes in there. But for principal diagnosis, this is where it's going to be like you have to be on it with the brackets. Because if you put FO2.80 as principal diagnosis for the dementia and you list G20 as a secondary diagnosis, your DRG would be different with FO2.80 as principal diagnosis. Okay? And usually, like, just going, let's see, for the test, for my test takers, you won't see it. You won't know. It would just be wrong if you selected to put the FO2.80 as principal. But when we're using encoders, when you get your career opportunity, right, you will be flagged as an error. It will say something like FO2.80 is a manifestation code. Please select the etiology, okay? All right. Here's a tip. When you see a bracketed code in the index, think secondary or manifestation. It comes after the primary condition. So I hope that helps. Let's move on to parentheses. Words in parentheses are non-essential modifiers. Whether they're in the note or not, the code stays the same. So let's look at that. So you're in the alphabetic index. We're going to stick with pneumonia. You index pneumonia. The diagnosis of pneumonia is all through the chart. We have to find the code. When we're in the alphabetic index, and if you have your books, you can follow along. Next to pneumonia, you'll see acute in parentheses, double in parentheses, migratory in parentheses. These are non-essential modifiers. So if the physician documented acute pneumonia, we would not have to go to pneumonia and go to the sub entry and find acute. No, we would see that in parentheses, we see acute. So the code would still be J18.9. All right. And that's if the organism was unspecified. Same here with fracture of the radius. You would index fracture, find radius in the subterms, right? And even if the documentation said shaft or close, it would be the same code. All right. Excuse me, guys. It's allergy season. Excludes one, not coded together. Excludes one equals never, ever, never, ever code these two things or codes together. We're going to pick the right family, okay? So, for example, if a patient has hypertension, essential hypertension, all right? So you go to the alphabetic index, you look up hypertension, you're going to see I10, excuse me. So when you go over to the tabular and you look for I10, boom, it says essential hypertension, but you'll see an excludes one note. When you read the excludes one note, it's saying if this patient has hypertensive heart disease, it's going to be coded with I11 point, there's a fourth digit. Hypertensive chronic kidney disease, I12. Hypertensive heart and chronic kidney disease, I13. Secondary hypertension, I15, okay? So what that means, and let me just break this down. So you've coded your chart and you have correctly coded hypertension to I10. All right. And then coding pneumonia and GERD and diabetes mellitus, you also have a code to represent hypertensive chronic kidney disease. So you see a code on your sheet for I12. I want you guys to know that those two codes cannot be coded together. All right. And that's what excludes one mean. You cannot code I12 with I10. All right. So, coach, which is the right one? The more extensive one, hypertensive chronic kidney disease. It's representing the patient has hypertension and chronic kidney disease. All right. These are combination codes that we call them. So you would not code just regular hypertension. So excludes two. We can code both if there's documentation of both. Excludes two equals the condition is not included here, but it can coexist. So code both. All right. So for example, let's look down at the acute kidney failure. All right. Acute kidney failure, N17, and it has a fourth digit. And chronic kidney disease. So the note says acute kidney failure with chronic kidney disease. All right. There's no combination code for it. We can code both of these. We can code them both. Excludes two says not part of this code, but it's allowed. Add another code, and you will see this in the tabular list. So let's just say our patient arrives at the emergency room dehydrated, all right? They find the patient is in acute renal failure, acute kidney failure. It is so bad, the patient has to have hemodialysis, okay? So of course, you're going to list that acute kidney failure as your principal diagnosis. It was present on admission, all right? And it meets the definition for principal diagnosis selection. You also notice in the H&P, our patient has chronic kidney disease stage 3. And you're like, okay, we have a chronic kidney and an acute kidney. So is the acute kidney going to trump the chronic kidney? It seems like it was pretty bad. No, if you're following your book, you're going to see an excludes 2, which says these codes can be coded together. All right, and look at this. So if you're dehydrated, right, it can lead to acute kidney failure. That's different than chronic kidney disease. All right, so those two can be coded together. And I have a practice part, but you see the answer after. We'll just go through it so you guys can just see it again. Doctor just wrote pneumonia. Is that NOS or NEC? That is NOS because it's unspecified. Doctor just wrote pneumonia. Doc wrote rare interstitial lung disease, not listed by any name, but he did put a type of interstitial lung disease. Is that NOS or NEC? That's NEC because he named it. The index or the tabular just did not have a code for it. So it is truly not unspecified. All right, it's just other specified. Index, the alphabetic index shows G20 with FO2.80 in brackets. Which one is coded first? We're going to code the etiology, G20, which is the Parkinson's disease, remember, and the FO2.80 as second, which represents the dementia in this case. All right. Hypertension with chronic kidney disease. Can I use I-10, just regular hypertension with both of those? Answer, no, because we're going to see an excludes 1 over in the tabular. Excludes 1 is going to push you to I-12, which is hypertension with chronic kidney disease. Okay, COPD with asthma, code 1 or both. You can code both. Excludes 2 allows it. So here's our checklist. Did the note get specific? If no, NOS. If yes, but no exact code exists, that's what NEC means, other specified. Do you see brackets in the index? Expect a second code for the manifestation. Do you see parentheses in the index? Ignore them for code selection. They are optional words. Excludes 1. Pick the correct family. Don't code both. Example, diabetes type 1, diabetes type 2. I want you guys to really look at this. A person cannot have type 1 diabetes and type 2 diabetes. You will see an excludes 1 in the tabular for type 2 or vice versa. Okay? Excludes 2, you can code both if documented. So I hope this helped you guys out today. Remember, the conventions are very important. They help us code within the book. The official guidelines help us code when we're outside the book or because we're still using the book. It's just when we're in the patient's medical record for the guidelines, okay? And always remember, the conventions trump the guidelines. So I hope this has helped you guys today. Again, subscribe if you haven't. Leave a comment if this helped you or if something that you want to see or need further explanation. And again, if you want to get into inpatient medical coding, I invite you to click the link in the comments or the description. Get started today. This is truly a skill that you can learn, work from home, and earn good money while doing it. I'll see you in the next video. Thanks for watching. Bye.